Okay, so the lower respiratory system is going to be lungs and everything inside of the lungs. So as we look, the trachea comes down and then splits into the primary bronchus or the main bronchus, and then goes out into your lobar or secondary to go to the different lobes of the lung, lobar. And then you get to segmental or the tertiary to go out to various places inside those lobes. So if you're looking at where it comes into the lung, this is called the hilum. And then from there, if you look at the left lung, you have two lobes, superior, inferior, and a cardiac notch where the heart sits. So your heart sits a little bit off to the edge, to the left side. And then on your right side, you're going to have superior, middle, and inferior. As we move down into the bronchial tree, so looking at this stuff, so we have our primary or your main, and then your secondary / lobar, tertiary, segmental, and as we move down, we're getting smaller and smaller and smaller and smaller, and you go from bronchi to bronchioles. When you get to these bronchioles, we go from that pseudostrat ciliated columnar to ciliated cuboidal cells. And then that continues down into your terminal bronchi, which is going to be the end of the conducting zone and the beginning of the respiratory zone with your respiratory bronchioles with the alveolar ducts and the alveolar sacs. When you look at the alveoli, they look like this. They look like little grapes in a bunch, right, at the end of these respiratory bronchioles. There's 3 different types of cells, and the main type of cell is going to be your type 1 alveolar cell, or these simple squamous cells. So it's just one layer, just like you see in the capillaries, which are surrounding here. So you have a layer of simple squamous in the capillary and a layer of simple squamous in the alveoli. You also find type 2 cells or great cells. Sometimes these are called surfactant cells because they secrete surfactant. They also repair any damaged alveolar cells. What is surfactant? Surfactant is something that breaks the surface tension of water. So if you put a drop of water on something, it's going to kind of round up like that, right? Because it has a surface tension. Water wants to get as small as it possibly can. And you have a layer of water around your alveoli, inside the alveoli, and what they're going to want to do is collapse that alveoli. But with the surfactant, it decreases that surface tension, and so it's not able to do that. Something that we see in premature babies is these type 2 cells are one of the last ones to be made, and they haven't started secreting surfactant yet. And so these babies, if they come out premature, they won't have surfactant, and their lungs will collapse, something called atelectasis. And they need this surfactant, and so you can just give them some surfactant into their lungs, and they'll inflate and they'll be able to breathe on their own. And then the last type of cell you find are dust cells, or these alveolar macrophages. These, again, come from monocytes that you find circulating out in the blood supply, and then they invade in here. I call them dust cells because they eat stuff like dust. Yeah. So, fluid in the lungs is a bad thing, right? Pneumonia is fluid in the lungs. So why is fluid in the lungs a bad thing? It's a bad thing because it takes too long for oxygen and carbon dioxide to diffuse across. And so with that decreased diffusion into the blood supply, then you start running out of oxygen for your cells. You have a bunch of capillaries associated with these alveoli, and they take any excess fluid and reabsorb it. And you also have a bunch of lymphatic capillaries that we're not seeing in here that are also associated with this to pull any extra fluid away from the lungs. Because you don't want fluid pushing on the lungs, and you don't want fluid in the lungs. And so we really want to take care of how much fluid we have around and inside the lungs. Something else that we know about our lungs is you have that visceral and parietal pleura. So the visceral pleura is going to be the pleura on the lungs, and then the parietal pleura is going to be the one attached to the wall of your ribs, of the thoracic cavity. Why do you have that pleura? One, to reduce friction. You know, it secretes that fluid that lets your lungs expand and contract without grabbing and pulling. It also creates a pressure gradient. So this pleura is attached to the wall and is pulling out. This pleura is attached to the lungs and is pulling in. And so you end up with a partial vacuum between the wall of the lung and the lung itself. And that partial vacuum allows the lung to inflate completely. Something that happens with stab wounds or punctures into this parietal pleura is it can let air in, and that causes something called a pneumothorax. Pneumo as in air, thorax into this thoracic cavity. You get air into this cavity, you take away that partial vacuum, and then that air is going to force its way onto this lung, and it's going to collapse this lung. It's going to make it very hard to inflate that lung or to breathe. And how you get rid of a pneumothorax is, one, you plug that wound, you make sure no more air is getting in there, and two, you get the air in here out. And so you could see maybe like in field op type situations, if someone got shot and they have a pneumothorax, they'll stab a syringe in their chest and pull out the plunger and let the air escape out. Okay, so what happens to a dust particle in the alveoli? Gets eaten by a macrophage. Palpate your laryngeal prominence. Where is that? It's going to be right there, right? What does the lamina propria have? Erectile tissue? So it can keep that lower conchae moist, right? So once it gets dry, the other one, or the dry one will engorge, and then the other one will have the air flowing past it. Contrast the epithelium of the bronchioles in the alveoli. Well, in your bronchioles, you're going to have simple cuboidal. In the alveoli, you're going to have simple squamous. All right, so our respiratory muscles. What muscle do you use to breathe? Well, the big one is going to be the diaphragm. When you're doing normal, everyday breathing, which is called euphenia, there should be no noise coming in or out. It's just nice, quiet breathing. You're just using your diaphragm. And so if you look at how your lungs are set up, you have this chamber, and your diaphragm kind of comes up like this when you're at rest. And then when you breathe in, that diaphragm contracts and pulls tight across. That creates a vacuum here in this area and allows air to come inside. Okay? And so when you're breathing, you're basically just making space for air to come in. And then when you breathe out, you relax that diaphragm and it bounces back, and whatever air is in here comes out. It's pretty cool stuff. But you can take deeper breaths if you want, not just those nice quiet breaths. And for that, you can use other muscles. So on inspiration, you can use your sternocleidomastoid, your scalenes, your pectoralis minor that you'll find over here on the ribs. Also, your external intercostals, and of course, your diaphragm. So that's on inspiration. When you want to breathe in, you see that everything lifts up, right? Open up that chest a lot more for inspiration. For expiration, again, for quiet breathing, that diaphragm just bounces back. But for active breathing, your internal intercostals are going to pull down. Your abdominals are going to compress, the ribs are going to push in to force out that air. And of course, your diaphragm pushing up. So, how do we control breathing? Well, breathing is rhythmic, right? You breathe in, you breathe out. But it's not auto-rhythmic. Auto-rhythmic would be something like your heart, that you don't control how fast it beats. But you can control how fast you breathe. Everybody take a breath. You did that, right? The only muscle that you can control voluntarily is skeletal muscle, right? And so your diaphragm is made out of skeletal muscle, and you have a whole bunch of other muscles with that. And so breathing is rhythmic, but it's not auto-rhythmic. And what makes it rhythmic is you have these centers in your brain. You have 3 of them. If we look right here, this is the pontine respiratory group in the middle of the pons. And then down here on the medulla, you'll have the dorsal and the ventral group. And these are important in controlling how deep and how fast you breathe. Things that have inputs on that will be central chemoreceptors, peripheral chemoreceptors, stretch receptors, irritant receptors. And so these areas in the brain are getting a bunch of input about what is going on in the lungs and the rest of the body. And you also have stuff like emotional. If you get freaked out or are having an anxiety attack, none of this is changing, but this is changing, and that's going to start causing you to hyperventilate, right? And of course, your higher brain levels, you can control that diaphragm, and you can make yourself hyperventilate, even if it's not like anxiety-induced or anything like that. So, your central chemoreceptors, this is going to be stuff picking up the pH in your cerebral spinal fluid. It happens on either side of the medulla oblongata, and it's measuring carbon dioxide concentration. So as carbon dioxide concentration goes up, that's going to cause these to go off and tell you to breathe faster or more. When you get out to your peripherals, these will be the ones that you find in your common carotid and also in your aortic bodies that respond to both oxygen, carbon dioxide, and pH. And so it's picking up on a whole bunch of stuff to try to even everything out. You have stretch receptors. You have smooth muscle in the bronchi and the visceral pleura that can pick up on stretch. Excessive inflation causes this thing called the Harry-Beer reflex. And this is how babies breathe. When they're taking a breath, they're just breathing in, and then that stretch reflex sets off, and then they relax. Breathe in, and then relax. Not typically used in adults. And then irritant receptors in the epithelia of the airways responding to smoke, dust, chemicals, whatever, to cause you to cough. If you damage these receptors in the pons and the medulla, you can get something called Ondine's Curse. It's a German legend where this water nymph took a mortal lover. He cheated on her, so she had the king take away his autonomic functions. And so he had to consciously breathe in and out, in and out. So he had to think about that all the time. And if he ever went to sleep, he would die. There's an actual disease called Ondine's Curse where if you had polio, where you start losing some of that autonomic function, or a neurosurgery accident, then you have to have a ventilator to sleep. So breathing is voluntary, and you have voluntary control, and you use that anytime you speak, sing, or holding your breath. All that comes from up here on the frontal part of your brain in an area called the precentral cortex. We'll talk about that. Or precentral gyrus. We'll talk about that more when we get to the central nervous system. But that's where you have skeletal motor control. And can you hold your breath until you die? No. Because you'll pass out, and then your brain will go back into automatic or autorhythmic function, rhythmic function. So, why does contraction of the diaphragm cause inspiration? Because it pulls down and makes space for the air to come in. But contraction of the transverse abdominis causes expiration. Remember that transverse? When you contract that, it's going to squeeze, right? And so that's going to force any air out. Why does eupnea or quiet breathing require little to no muscles? All it needs is the diaphragm to contract and relax, right? It's just basically doing that. Very little muscles needed. We will pick up with alveolar gas exchange next time.